Today we will discuss more questions in CMS forms. We'll see this question first. Which of the following is most likely to have prevented this condition? So he's asking about prevention. A 77-year-old man is brought to the emergency department 8 hours after awakening with a right-sided weakness and inability to speak. So right-sided weakness and inability to speak after awakening, the one most important differential diagnosis is stroke or infarct or hemorrhage. He takes digoxin for atrial fibrillation. So atrial fibrillation is the risk factor he's talking about. His temperature is 37, pulse is 88, irregular respirations are 20 and blood pressure is 140. Examination shows there is right-sided hemiparesis with weakness greater in the upper than the lower extremity. His language is non-fluent and he has difficulty naming objects. So he has difficulty naming objects and repeating the words. His comprehension is mildly impaired. Carotid ultrasonography shows less than 50% stenosis bilaterally. Which of the following would have most likely prevented? So this patient has got atrial fibrillation. When we have the atrial fibrillation patients, we usually calculate CHAD's 2 VASC score. CHAD VASC score. So this patient is a man who has got atrial fibrillation. So in order for this incident to be prevented, we will have to start him on anticoagulation. The most important anticoagulation we use is warfarin therapy. We'll also have to understand that patients with atrial fibrillation needs to be calculated for CHAD VASC score. What is CHAD VASC score? CHAD VASC score is nothing but patient who has got the risk factors and we will have to calculate them. The most important being congestive heart failure, hypertension, age more than 75, diabetes, stroke or TIA, which carries most of the important points, that is 2 points, and VASC is vascular disease, which carries 1 point. A is age 65 to 74 and sex female, which carries 1 point. So when we talk about other options in this question, talking about atenolol, usually atenolol is used in the treatment of hypertension, sometimes can be used in the treatment of arrhythmias as well. Clopidogrel is usually used for stroke. Antiplatelets do not have any role in the prevention of risk factors related to atrial fibrillation. Next we talk about hydrochlorothiazide. This is an antihypertensive medication usually used for hypertension. Next we talk about carotid endarterectomy. Carotid endarterectomy is usually done in patient with severe carotid atherosclerosis. But this patient has got a carotid stenosis of less than 50%. So that's one most important thing we will have to remember in this question. Next we will talk about another question. We'll solve another question. This question is pretty long. So first I'll have to look at the options and what he is talking about. Which of the following is the most likely diagnosis? Charcot-Marie tooth disease, inclusion body myositis, myasthenia gravis, myasthenic Lambert syndrome and polymyositis. Remember, 55-year-old man with emphysema is brought to the emergency department with a 5-month history of weakness and fatigue in the legs. So he's talking about some chronic problem, chronic issue of weakness and fatigue. One most important thing. His symptoms briefly improve if he walks a short distance and worsen if he continues walking. So weakness worsening on activity. During the past 4 months, he has been unable to maintain an erection and has had dry mouth. So he's got some bit of extra features as well. He has a 5-year history of unstable angina pectoris, but he has not had any recurrence of pain since undergoing placement of 2 coronary stents 2 years ago. His medications are diltiazem, atenolol, and low-dose aspirin. Diltiazem, atenolol, and low-dose aspirin. He smokes 2 packs of cigarettes daily for 35 years. Pulse is 68, respirations are 18, blood pressure is 120 to 78. Pulse oximetry on room air shows oxygen saturation of 96%. Pulmonary examination, breath sounds are decreased on the left lung. Carotid examination shows no abnormalities. Neurological examination shows mild dysarthria in the lower extremities. Muscle strength is 4/5 proximally and 5/5 distally. Deep tendon reflexes are intact. With the repeated testing, they are 2+. The remainder of the examination shows no abnormalities. Which of the following is the most likely diagnosis? Basically, this patient has got weakness and fatigability, which worsens if he is walking and his symptoms are briefly improving. That is one most important thing we will have to remember, please. And he also mentions that on repeated testing, the reflexes are improved. And now this patient has also got some emphysema smoking, and which has been present in the lung. And this patient has also got autonomic features involving the dry mouth and has also got some erection problems. There is no fatigability that is demonstrated. But given that this patient has got history of smoking, with history of lung problem, with history of autonomic disorders, with improving symptoms on repeated testing, I would like to think of myasthenic Lambert syndrome as one of the most important diagnoses. Remember, whenever there is history of autonomic dysfunction with reduced reflexes, with improving reflexes on repeated testing, you will have to think of Lambert-Eaton myasthenic syndrome. This Lambert-Eaton myasthenic syndrome is usually because of the formation of voltage-gated calcium channel antibodies at the neuromuscular junction. This Lambert-Eaton myasthenic syndrome is usually associated with malignancies, especially the lung malignancy we are talking about. Remember, initially there will be areflexia, but on repeated testing, the reflexes will be coming back positive. Sometimes the autonomic features are also present. Usually in this patient, it is the dry mouth and the erection problems. There can also be questions which when mentioned there is decreased salivation, or sometimes the examiner can tell you about a postural drop as well. This is all we talk about Lambert-Eaton myasthenic syndrome. We'll also see why not other options. Charcot-Marie tooth disease is generally sensory motor neuropathy, but this is symmetric sensory motor neuropathy. If the patient has got chronic disease, it is usually pes cavus or contractures that we usually see in Charcot-Marie tooth disease. Most of the times it is the distal limbs that are affected, or distal part of the limbs that are affected. Next, we talk about inclusion body myositis. Remember, inclusion body myositis is an inflammatory disorder involving the muscles. It usually presents with progressive muscle weakness, and there will be involvement of the proximal muscles. Very important in inclusion body myositis, there will be involvement of the proximal muscles. There will be increased serum creatinine kinase as well. Next, we talk about myasthenia gravis. Myasthenia gravis, usually there will be mention of fatigability, there will be mention of diplopia, there will be slurring of speech. Remember, if the patients have got myasthenia, it is basically because of the formation of acetylcholine receptor antibodies. And there will be characteristic symptoms as well. The reflexes are normal in myasthenia gravis, but the reflexes are reduced here. Tendon reflexes are 1+. Next, we talk about polymyositis. Polymyositis is also an inflammatory inflammatory condition affecting the proximal muscles. They are usually seen in close relation with middle-aged women. Please do make sure that whenever you think of polymyositis, it is usually because of the inflammation or usually because of the infiltration of the endomysial CD8 positive inflammatory infiltrates. And polymyositis usually presents with pain and weakness, but the patients will not have improvement on repeated testing. Very important, please. This is how we'll have to see all the options and the questions in USMLE exam. But remember, the characteristic questions will be asked directly. This is a short question, so I'll read the stem. A 4-year-old boy is brought to the physician by his mother because of a 4-month history of sleepwalking. He goes to bed every night at 7 p.m. These episodes begin about 1 hour after he falls asleep and occurs every 2 weeks. He never hurts himself or others while sleepwalking. Physical examination shows no abnormality. Which of the following is the most appropriate next step in the management of this patient? Whenever there is sleepwalking in a child, that is a normal condition or a common condition. We call it as parasomnia. Usually, the sleepwalking in children can vary. It can vary from just walking to frequent running. Sometimes the patients can also walk outside the home. Remember, this is normal in children. But if patient has got other comorbidities such as snoring or any other abnormalities, it is usually the polysomnography that we will have to do. Here the patient is just walking, not got any dangerous things, so we will have to do nothing, but we will have to reassure this patient, please. We will see the other options as well. Recommending a later bedtime does not usually improve the sleepwalking. So remember, if it is non-dangerous, it is reassurance. If it is dangerous or if it is associated with other comorbidities, usually polysomnography needs to be done. Next, multiple sleep latency test is done for narcolepsy. Multiple sleep latency test is done in narcolepsy. This patient does not have any features of narcolepsy. If you have narcolepsy, usually patients present with cataplexy or hallucinations. And next, patient has got a psychiatric assessment. No need of psychiatric assessment. He's talking about a children, 4-year-old, does not have any other symptoms. No need of psychiatric assessment. Next, we talk about diphenhydramine therapy. Diphenhydramine therapy is usually not needed. If you want to use any of the medications in patients who has got sleepwalking, it is basically the clonazepam that we usually do. All right. We'll see the next question. This is quite a big question. I'll have to first read what the examiner wants. Which of the following additional findings is most likely to be found in this patient? Decreased postsynaptic acetylcholine receptors, demyelination of the spinal cord axons, focal degeneration of the peripheral sensory neurons, inflammation of the cerebral arterioles, meningeal inflammation. 37-year-old, quite young woman comes to the physician because of a 1-week history of numbness of her left arm and right. So this is an acute to subacute problem. During this time, so she's got numbness of the left hand and arm. During this time, she also has poor short-term memory and electric shocks that run down her back when she flexes her neck. Very important point. She reports 2 previous episodes of the left arm numbness during the past year. The first occurred 6 months ago and lasted 1 week, and the second occurred 4 months ago and lasted 6 weeks. So 2 episodes of left arm numbness in 1 year, and these symptoms are separated by 6 months ago, which is usually lasting 1 week, the first episode, and the second episode occurred 4 months ago, usually lasting for 6 days. So we will have to remember this. She does not recall what precipitated the numbness in the past, but she observed that most of the recent episode began after she took a hot shower. She was successfully treated for Neisseria gonorrhea infection at the age of 18. Sensation to pinprick is decreased over the left forearm. The remainder of the examination shows no abnormalities. Which of the following is most likely found? I will have to think of the lesions separated in space and time. So I will have to think of multiple sclerosis as one of the most important things. So demyelination of spinal cord is one most important differential diagnosis. Basically, he's talking about self-resolving episodes usually separated in space and time 6 months apart. That is the characteristic of multiple sclerosis, usually the demyelination. Remember, patients with multiple sclerosis presents with optic neuritis as one most important thing. So 50% of patients with optic neuritis can have lesions in the brain. So you will have to differentiate or rule out the demyelinating disorder by doing an MRI scan of the brain. Remember, the second most common presentation could be possibly because of a trigeminal neuralgia presentation. Whenever there is trigeminal neuralgia presentation, again you will have to do a MRI brain in order to rule out any other demyelination syndromes, please. We'll see other causes as well. Decreased postsynaptic acetylcholine receptors. This is basically myasthenia gravis. Whenever there is myasthenia gravis patients, fatigability is one most important thing the patient can present with. Next, focal degeneration of peripheral sensory neurons can usually be seen with association of any of the peripheral neuropathy that can present with the tingling, but it is not usually separated in space and time. So you'll have to think of that. This is not an option. This is not associated with an infection as well. Inflammation of cerebral arteries. Usually cerebral arterioles is associated with vasculitis. However, this can be seen in young patients such as this female, but they are not separated in space and time. Usually associated with autoimmune conditions, the inflammation, it is also called as cerebritis. Whenever there is inflammation or cerebral vasculitis, presents with headache, confusion, and focal neurological deficits. Next, we talk about meningeal inflammation. Whenever there is meningeal inflammation, people usually present with meningitis. Patients with meningitis are usually sick and fever, neck stiffness, neck rigidity will be present in patients with meningitis. This patient does not have any of these things. So the answer is demyelination of the spinal cord. Usually the lesions are separated in space and time. We'll see the next question. Which of the following is the most appropriate next step in the management? Lumbar puncture for CSF, MRI of the entire spine, oxycodone therapy, physical therapy, and X-ray of the lumbar spine. A 46-year-old woman comes to the office because of a 3-week history of moderate low back pain. She works as a personal care assistant and says her back pain has begun after she transferred a patient. She has had difficulty sleeping because of the pain despite treatment with ibuprofen and acetaminophen with codeine. The patient adds that she has had a dull headache over her entire head for the past 2 days. Medical history is remarkable for hypertension and type 2 diabetes mellitus. Medications are lisinopril and metformin. She is 165 centimeters tall and weighs 82. BMI is 30. Vital signs are within normal limits. Physical examination discloses that there is hyperlordosis and there is paraspinal muscle spasm. Muscle strength is 5 by 5. Deep tendon reflexes are normal. Sensation is intact. Gait is slow and antalgic gait. What is the most important thing that you will have to rule out? This patient presenting with moderate low back pain, who is 46-year-old female and she works as a personal care assistant. She transferred a patient and then the symptoms started. There is an exciting or exacerbating cause for this back pain. So she has got difficulty sleeping and the pain, because of the pain despite a treatment. First most important thing I will have to remember is, after the transfer of a patient with the paraspinal muscle tenderness is basically a musculoskeletal pain. There is no need of doing a lumbar puncture in this patient because this patient has not got any fever, neck stiffness, meningitis or encephalitis symptoms. So you need not do lumbar puncture for CSF. MRI of the entire spine. There is no new neurological examination findings that needs an MRI. That is hyperreflexia or upper motor neuron lesions. Oxycodone therapy. She is already on codeine, acetaminophen and ibuprofen. I will not add any other oxycodone therapy. Whenever there is oxycodone therapy, it should be used only if the patient has got severe back pain or if the patient has got refractory back pain. Remember, this patient has got musculoskeletal pain which can be resolved with the physical therapy. Physical therapy is nothing but patient can be given massage or heat therapy. Whenever the patient has got tenderness and everything, please do check for any other alarming signs and then that will decide the investigations, please. X-ray of the lumbar spine is usually done if you are thinking of a fracture, but for this patient you don't need to do a X-ray of the lumbar spine. We'll see the next question. It's got plenty of options. So which of the following is the most likely location of the onset of her symptoms? A 16-year-old girl is brought to the physician because of a 6-month history of episodes of visual loss in her right visual field that occur every 2 weeks. So she is a 16-year-old because of a 6-month history of visual loss. So it is happening every 2 weeks. The visual loss occurs suddenly, lasts about 5 to 10 minutes before gradually resolving. She occasionally has headache, vomiting and loss of balance as the visual loss is resolving. She has no history of serious illness, takes no medication, blood pressure is normal. Examination shows intact cranial nerves, visual acuity is intact, visual fields and ocular motility is intact. The remainder of the examination shows no abnormalities. Which of the following is the most likely location of onset of the symptoms? So is it a left frontal cortex? Left frontal cortex usually associated with executive function, not the cause. Left occipital cortex. Possibly occipital cortex is involved with the vision, but there are 2 occipital cortex in this. Is it the right or the left? We will have to think of. This patient has got a right visual field. Right visual field is usually controlled by the left occipital cortex. So I will have to keep this in my books. Left retina, usually whenever there is retina, they do not cause self-resolving things. and she's also got severe headache, vomiting, and loss of balance. So the examiner is talking about something that is basically in a 16-year-old. So I will think of migraine because there is no risk factors in this patient to consider as a stroke. So migraine is a possibility here, especially occipital migraine is what the examiner is talking about. So whenever there is left retina involvement, the patient usually have got prolonged visual field defects. Left temporal cortex, I'm not worried about temporal cortex because temporal cortex usually causes quadrantanopias. There is no mention of quadrantanopia here. Right frontal cortex, again patient will be having involvement of the executive function, which is not the case. If the right occipital cortex is involved, it is usually the left visual problems the patient has got. Right retina leads to right visual blindness or decreased blindness. Again, right temporal cortex usually causes the superior quadrantanopia. So in this patient, the diagnosis is migraine. When the patient has got a diagnosis of migraine, usually presents with headache or any oral symptoms, and then the patient has got a gradual resolvement of the symptoms in migraine. Remember, in children, the patient has got bifrontal headache. You will have to think of migraine. Migraine can also present with nausea, vomiting, aura, sometimes hemiplegia. This patient, there is involvement of visual fields, so that is why I'm thinking of occipital cortex as one of the most important location because it controls the visual fields. We'll see the next question. This is an image based question. Whenever I see an image, the image has got a nice, neat, well circumscribed border. Keeping that in mind, I will first rule out glioblastoma multiforme. Which of the following is the most likely diagnosis? Healthy 62-year-old woman brought to the physician because 3-month increasing history of severe occipital headache. She now has had a headache on morning awakening. So he's talking about raised pressure. She has stopped driving because she has difficulty seeing objects on the left side. She's got visual symptoms as well. Temperature is normal, pulse is normal, blood pressure is normal. Cranial nerve shows an examination of left homonymous hemianopia. Fundoscopic examination shows bilateral papilledema. Muscle strength is full. Deep tendon reflexes are 2+ in the right upper and lower extremity and 3+ in the left upper lower extremity. Very important examination findings here. So muscle power or strength is normal. Deep tendon reflexes are 2+ in the upper extremities. And he's talking about lower extremities that are 3+, so bit increased in the lower extremities. Babinski sign is absent, sensation is intact, axial and coronal views of the MRI brain with gadolinium contrast are shown. So this patient basically has got a nice neat circumscribed mass. This patient has not got any fever, so there is no chance of having an abscess in this patient. If the patient has got a brain metastasis, usually brain metastasis can also present with increasing headache, but they appear to be presenting at the gray-white matter junction. But this is not the case here. Glioblastoma multiforme, the mass will be irregular, please. And whenever there is glioblastoma multiforme, there will be altered mental state, there will be headache as well. And remember, the prognosis in glioblastoma multiforme is usually less than 18 months. Some books say it is less than 1 year. Next, we talk about the intraparenchymal hemorrhage, usually sudden onset of symptoms. But this patient has got a 3-month history of increasingly occipital headaches, so it is not intraparenchymal hemorrhage. Meningioma is in my books because this patient has got a meningioma which is got a nice neat circumscribed mass and has got chronic symptoms. Very important. Usually calcifications are seen. Whenever there is meningioma, the symptoms are chronic and usually and gradually progressive. This patient has got a uniform enhancement on the imaging. Remember that this is very important finding to call it as a meningioma. If you want to do a definitive diagnosis, it is usually by the biopsy, where we do a histological examination for the demonstration of some MOMA bodies. Usually the treatment for meningioma is you will have to remove it by surgery. Sometimes if the patient has got seizures, you can do anti-epileptic medications or drugs as well. Thank you very much. I'll see you in the next video.